Greetings and welcome. Thank you for your patience as I pull up the proper slide deck this morning. My name is Sarah Pennebecker and I'm the Assistant Director of Alumni Relations at the University of Minnesota School of Public Health. We'll be moderating today's session. Thank you to all who are joining us for our webinar about public health's role in advancing diversity, equity, and inclusion. We are joined today by Dr. Antonia Apolinário-Wilcoxon, Dr. Nathan Camillo, and Shirlynn LaChapelle, and I'll introduce them more formally soon. There are things each of us can do to combat injustice and racism. We can work to understand its roots and symptoms, challenge ourselves to explore our own thoughts, feelings, and biases, find ways to build upon our work with community partners to make a lasting difference, and speak up when we witness racial injustice. Thank you for choosing to spend time learning with us today during today's event. And before I forget, thank you so much to the many volunteers who helped plan and make this webinar possible. In a moment, I will turn it over to our presenters, but before we begin, I'd like to share a few updates and housekeeping notes. On July 26th, the School of Public Health will officially launch our 5-year strategic plan for anti-racism. The goal of this plan is to transform SPH into a school where there is justice and equity for all. Everyone has the same opportunities to contribute and thrive, and each person feels welcome and respected. In order for true change to happen, we have to be willing to shift our beliefs, attitudes, and actions towards equity and justice. And that's why conversations like the one happening today are so important. I'm incredibly grateful to our presenters for their willingness to share their expertise on diversity, equity, and inclusion to help us continue to learn and grow. I also invite you to check our website anytime after July 26th to review our strategic plan. Please consider joining us again on July 27th for another important event. This time on anti-racism research for health equity, featuring SPH Associate Professor and alum Rachel Hardiman. Dr. Hardiman will be joined in conversation with Marissa Evans, staff writer of the LA Times. During the event, our experts will explore the vision and promise of anti-racism research and its role in improving health equity. Dr. Hardiman will describe the need to knows about anti-racism research, a revolutionary method grounded in the reality of racism's impact on health. She will share the vision of the new Center for Anti-Racism Research for Health Equity and the impact of this research for long-term change. The event is free and open to the public. Please invite anyone who would benefit from the conversation. And you can register today at the link shown here on the screen. So questions are welcome during this webinar at any time, and you may submit them throughout the webinar. Our audience Q&A will be at the end of our hour together after our 3 presentations. Please type your questions by clicking on the Q&A, not the chat button on your screen, and we'll get to as many questions as we can with the time allows. Now let's get to this topic at hand. So I'm so pleased to introduce you our first presenter today, Dr. Antonia Apolinário-Wilcoxon. Dr. Apolinário-Wilcoxon is a principal consultant for Equity Strategies, LLC, where she provides direction and leadership in efforts of private, public, and collaborative efforts working to improve the lives of disenfranchised and vulnerable persons impacted by inequities. An African Brazilian, she brings experiences in education, corporations, private nonprofits, and government to lead efforts that bring agency, voice, and liberation in spaces where the presence of oppression, bias, and barriers silence those most valuable voices to find solutions to problems in their world. Today, she'll be presenting on the challenge of advancing equity inside the Minnesota paradox. Dr. Apolinário-Wilcoxon, I'm so happy that you're able to join us today. I'll turn it over to you. Please take it away.
Thank you, Sarah, for that kind remark. I am very pleased for the invitation and very happy to be here with esteemed colleague Shirlynn, as well as Dr. Chomilo. We serve on an advisory group together. I'm going to start by talking a little bit about my first beginnings as an immigrant here in Minnesota, a little bit about my professional life, and then I'll end with the subject at hand. What's this Minnesota paradox, as Dr. Sam Myers calls it? For those who don't know me, I arrived here in March 1979, and I was returning to a state I had lived as an exchange student for a year back in 1973. I remember on the plane, on the travel here, questions from acquaintances were innocent enough. Do you know how cold it gets in Minnesota? The year is mostly covered under snow. Are you sure you're going to do this well? I was newly married and the future looked bright, and so it seemed. Minnesota ranked high on so many areas, it was impressive. Nainville's achievement in education, an exemplary early childhood and family education program touted as available to young families, an infrastructure that worked. When it snowed, we could still drive because the semis and the trucks were on the road before we got out. People were very nice. I started, though, with the uncomfortable feeling that I was saying, I am sorry for things I did not know I had done, or that people never invited me to their home, though I invited them to our apartment. Having a multicultural baby during that period was viewed and reacted by some as abnormal. I come from a place where people fawn over newborns. I had a traumatic incident during childbirth that almost killed me and my baby. When my husband proposed and I would ask him how his family would accept me, a Black woman, an immigrant from a global South country that back then was called underdeveloped country, he said, oh, they don't have a problem. I was going to be well accepted. When my oldest was 8, he came home from elementary school quite upset one day. Mom, I finished that math problem all by myself, but the teacher didn't believe me. My heart sank. What can you tell an 8-year-old? I learned early on to put together my 2 sons' broken spirits as they came home, troubled by why they were being treated differently. As I began my career, I recall one particular job where this first and only Black supervisor gave me the following advice. Each 2 weeks you're paid. It is the symbol of your completion of tasks, and they do not know you anything else. If you get a compliment, consider it gravy, but never expect it because you will not receive it. I learned to work twice as hard to be considered many times half as valued. Yes, there is racism in Brazil, and there is classism in Brazil. It was not foreign to me, but it does have an American tone. It was confusing for someone who had learned about this great state from reading the headlines. It's a great state to live. We have good schools, good hospitals. Why then these wide disparities? I have lived in this great state as an immigrant for now over 40 years. Minnesota is a wealthy state. I have managed national grants for the state of Minnesota and heard from other states officials about our general public social services scheme and progressive action. While traveling for work, I recall many conversations when I mentioned I lived and worked in Minnesota. Oh, you have that brilliant senator, Wellstone. He will go quite far. Mary Kennedy is your Medicaid director. She's fabulous. Former Vice President Mondale, former Vice President Hubert Humphrey, and his role as the floor leader in the 1964 U.S. Civil Rights debate in Congress. I was and still am to call Minnesota home. Very proud of that. When I left corporate employment in international finance to lead a historically Black community-based organization hailing its beginnings from the war on poverty as its executive director, I found my calling. I have a firm belief that solutions to problems that challenge low-income, marginalized communities are held by these people. As large bureaucratic institutions, we must learn to better listen, to be better listeners, better partners, and best collaborators. Their wisdom, brilliance, and hopes and dreams lay dormant. If only we get out of the way and help unleash them. However, these populations, usually Black and brown, red, yellow, do not stand a chance. Minnesota is one of the best places to live in America. Minnesota is also one of the worst places for Black people to live. African Americans are worse off in Minnesota than they are in virtually every other state in the nation. Racial gaps in unemployment rates, wage and salary income, incarceration rate, arrest rate, home ownership, mortgage lending rates, test scores, reported child maltreatment rates, school disciplinary and suspension rates, and even drowning rates, land of 10,000 lakes. Dr. Sam Myers at the Roy Wilkins Center for Human Relations and Social Justice at the Humphrey School dubs it the Minnesota Paradox. I thought of him when I chose the title for this message today. He sent me valuable materials that I include in this presentation. It has not always been this way in Minnesota. According to Dr. Myers, at one point in the history of Minnesota, Blacks were building communities across the Twin Cities. Roy Wilkins, a native of St. Paul and the first Black editor of the University of Minnesota student newspaper, the Minnesota Daily, went on to become the executive director of the National Association of Colored People, the NAACP, from 1954 to 1978. The University of Minnesota Medical School at one point produced more Black physicians west of the Mississippi River than any other university in the country. The first Black priest of the St. Peter Claver Catholic Church, a predominantly Black parish in St. Paul, was one of the first Black priests ordained in the United States. The Twin Cities was known for highly accomplished, professional African-American women and men who helped to create the success story that makes Minnesota such a great state to live. The small number of Black households face brutal redlining practices, racial covenants, and limitations to what types of jobs they could hold. Blacks were admitted to the University of Minnesota nursing schools, but were denied housing in the dorms. Historic Black neighborhoods were destroyed by the federal highway after the World War II. Policing policies substitute racial profiling with scientifically administration of racially disparate arrests. Child welfare and public housing policies served as magnets for communities in the urban core of Detroit, Chicago, Gary, Indiana. Minnesota perceives itself as liberal and progressive, opening its doors to the poor and oppressed. Unfortunately, social service institutions employ officials who create and perpetuate racism and racial discrimination, where disparities began to be baked into the structure of life in the state of Minnesota. College graduates, architects, engineers, economists are no different than the masses that many Minnesotans privately despise. These Black professionals are just as likely to be stopped and frisked by white security guards when they enter Target, or stop driving their Mercedes along Lake Street, made famous in Prince's classic Purple Rain. Minnesota is a state without races. You can be punished, persecuted, and lose your livelihood when you challenge this or name it. White supremacy is insidious, it is powerful, and it is unrelenting. Over 3 decades of working in environments where I made the decision to keep my focus on the prized destiny, I have suffered. I have always had the clarity that my vision was that what I would call Mrs. Smith down the street deserved quality social services and positive outcomes, and that young Jimmy would not be scarred by a child welfare service system that is less compassionate or safe for Black boys and girls. I had the full understanding and clarity that I would not see the fruits of my labor as I worked towards disparities reduction to see that inequities would be eliminated. It is daunting work that refuses to budge, stubborn, because like Mr. George Floyd's humanity was ignored, the other in Minnesota is invisible. So what's the future of public health and equity in this great state? I believe that it is in our hands, hearts, and heads. We all know at a certain level within us what to do, how to do it, and when to do this. We know, we have studied our communities to death. They are tired of investigators, they are tired of researchers coming and asking them questions. This is about our future, and it is about our humanity. I thank you.
Thank you so much, Dr. Wilcoxon, for all that you shared with us. Thank you for sharing your personal experiences as well as reminding or teaching some of us on this webinar today about just the incredible disparities in the state. I think it's so important to be able to highlight those. So our next presenter is Dr. Nathan Chomilo. I'm so excited to be able to introduce him today. So Dr. Nathan Chomilo is the medical director for the state of Minnesota's Medicaid and Minnesota Care programs, and practices as a general pediatrician and internal medicine hospitalist with the Park Nicollet Health Services and Health Partners. His work has been recognized by the City of Minneapolis Department of Civil Rights, which recognized him as a 2019 History Maker at Home recipient, and Minnesota Physician, which named him as one of the 100 most influential healthcare leaders in 2020. In March of 2021, he joined the Minnesota Department of Health to lead their vaccine equity team as part of the COVID-19 pandemic response. Today, he'll be presenting on building racial equity into the walls of health policy. So Dr. Chomilo, I'm so happy that you're able to join us, take time out of your incredibly busy schedule to join us today, and I'll turn it over to you.
All right, thank you. So happy to be here and continue to build on that kind of great intro that Dr. Wilcoxon provided as we kind of shift to talk about, our communities do face disparities. They're incredibly resilient in the face of systems that have been equitable. And so how do we build racial equity into the walls of health policy? I like to begin talks by acknowledging the land on which I gather is the seized territory of the Dakota people. And when we're talking about equity and we're talking about systemic oppression and racism, really important to recognize that land seizure has been a big part of our history that we continue to need to acknowledge and work to redress, because the folks and communities impacted by it are still here with us. So over a year ago, I and other colleagues wrote a piece in the Health Affairs blog talking about the harm of a colorblind allocation of scarce resources, really reacting to some of the frameworks that have been published around what to do during the COVID-19 pandemic if there was a critical shortage of resources like ventilators, ICU beds, and how they took a very almost uniformly colorblind approach to the systems and inequities that were in place, and that using those frameworks that were colorblind would perpetuate disparities that were already existing. And when you take a step back and think about it, healthcare of itself is really at baseline a scarce resource. And so the framing of, how are we going to use this one specific allocate this one specific scarce resource during a pandemic can really be and should be applied to how are we going to really look at allocation and utilization of the healthcare overall as a resource. And so, within that, we argued for the examining policy through a critical race lens, and in contrary to what you might hear on certain news stations, critical race theory is actually based on legal studies grounded in social justice and looking at the impact of systems and decisions and how race plays a place in that. And so one of the things that we really advocated for is that going forward, decisions being made utilized a racial equity assessment, or were used and looked at through a racial equity lens. We referenced Seattle's Race and Social Justice Initiative's Racial Equity Toolkit. Here you see what a racial equity assessment looks like from the local and regional government alliance on race and equity. But it's really having folks start asking questions about what is the existing inequities that you see along the lines of race, what are possible root causes and factors, what are you proposing, and how will that increase or decrease racial equity? How are you going to monitor for unintentional impacts or consequences? And how are you going to really work with community to be held accountable? And so from there, looking at what health policy can do, we need to start to think about, how does health policy get made? And often it is made on the basis of what we see in the literature. And so then you think about how does the literature get made? And that is looking back to grants and funding and who's doing the work. And so let's start by looking at our funding and grants. And is our funders like the NIH, actually crafting grants? Are they actually evaluating proposals with a racial equity lens? And starting there at the very start is one of the very first steps when I talk about building racial equity into our health policy. And what you see on the left there is a piece by Dr. Rhea Boyd and colleagues that really laid out rigorous standards then for once that work is ready to be published, how are we talking about and publishing on health inequities, and looking at what is a racial equity assessment actually being used and operationalized in research publishing once that information is actually generated. And so really starting in the process of building policy to think at the very beginning, how do we build racial equity? How do we see that the research that's being done, is it really actually in tandem with communities' needs and own assessments? Is it looking at even how the funding is being structured? Are we actually paying, getting money into the community, or are we just taking these large sums of money and continuing to contribute to racial inequities based off of who gets access to it, where the money actually goes? While research unfolds over months and years, policy is continue to be created, and even more so rapidly in response to the COVID-19 pandemic. And so really thinking about what are some of the ways that we can start working on our policy right now to build more racial equity into it. And so this is a group I helped co-found and part of Minnesota Doctors for Health Equity. Last year, got together with 7 other Minnesota physician organizations to really ask for a declaration of racism as a public health crisis. And that is a way for us as physician organizations, and so as health professionals, but as well as for our legislators to really start thinking about how they could better build racial equity into our policy and into our healthcare system. And that really includes engaging in with communities that are most impacted by structural racism to help co-create solutions. Again, incorporating those racial equity assessments to all decisions and all policymaking activities, looking at how we spend our funds and making sure the organizations that we're working with also embrace anti-racism. Looking at basic things like how do we make sure employees in healthcare get a living wage, get basic services like paid family medical leave that have been shown to help decrease disparities, eliminate policies and systems that reduce access to care, looking at how we actually even use race in medicine, and then kind of speaking a little bit to Dr. Wilcoxon's piece about the workforce and the importance of workforce development. And so we've called for, a racial equity lens to be applied, but any tool that relies on data, which many racial equity assessments do, you have to look at that baseline data to see, how race or structural racism might be at play in a certain situation. And so, that tool is only good as the data or the inputs that get put into it. And so we really need to have accurate and standardized data around race and ethnicity to really be able to effectuate and operationalize many of these calls to build racial equity into our health policy. And so, one gaps we see, within our Medicaid program is that, currently there's roughly a quarter of enrollees that we don't have accurate race and ethnicity information for, and that's due to a number of reasons. There have been movements at the federal level to try to put in place provisions, as you can see on the right, as part of the ACA to improve federal collection of demographic data to really kind of study and be able to target disparities. But the standardization of how you actually create the categories, and so that you can have some of those consistencies, particularly if you're trying to really match numerators and denominators and populations, is still lacking. And so continue to work on how we can improve the use of race and ethnicity data. Disability data is another big area. Being able to disaggregate even from these broader categories down into the different communities within these broad race and ethnicity categories are all important steps to really be able to then take the racial equity lens and operationalize it. So there are opportunities to do this. We can continue to engage folks as they're signing up for health insurance or coverage. Continue to engage those who help people navigate our health insurance marketplaces, looking at how we can try to get some of that information from other pieces and other sources of data. And I think there's also a piece of understanding where using race and ethnicity data and using technology can actually go awry. And so there's been a use of algorithms that look at things like trying to target more resources based off of utilization. But when you look at utilization alone without going through a racial equity lens, what you see is that utilization captures people that actually have access to the system and have less barriers to getting into physician offices and other services. And so we've actually seen that it can worsen disparities because it disproportionately shifts resources to folks who have less barriers already, which is largely seen along lines of race in our society. And so being really cognizant and having investment in the infrastructure, having investment in the staff so that they understand more and more about structural racism and some of the blind spots that might contribute to setting up systems trying to address a problem where we ended up actually worsening it. And so really it's important to kind of understand how, that last piece kind of ties that, how implicit bias, understanding, and how we need to work with individuals to understand our own blind spots, but then we also need to be aware of how our systems have been designed and have created over hundreds of years these health inequities, and these health disparities come from structural inequities and decisions that have been made over and over that disproportionately impact one part of our community over the other. And so what we really need is, leaders with the courage to address racism, not just equity or social equity, not just DEI, but really name it. And then, looking and even evaluating funders, researchers, policymakers, leaders on their racial equity impact and the policies that they're moving, the programs they're moving, what is the racial impact, and how can we evaluate their success through that lens. Because at the end of the day, racism, as Dr. Camillo-Jones notes, it saps the strength of the whole society through the waste of human resources. And so this is something that is not just done to help those that have been left behind, but really it's something that we need to be framing as a conversation that if we want to reach our full potential society, this is something that's critical and we need to address together. You can find me a couple places on Twitter, and look forward to the conversation going forward. So thank you.
Thank you so much, Dr. Chomilo, for all that you shared with us. I learned a lot about health policy, the use of demographic data, and how implicit bias shows up. There's a lot to think about, certainly, and reflect on. So thank you for your time today. Our third and final presenter today is Ms. Shirlynn LaChapelle. Shirlynn is the president and CEO of Nursing is the Answer, LLC. Her goal is to holistically and positively impact the health of persons, specifically those in the African-American community and in other communities of color. Her biggest achievement is being able to compassionately address the needs of the community through education and teaching self-advocacy, empowering community members to be able to access and utilize the healthcare system. Today, she'll be presenting on Is Minnesota Committed to Doing the Work to Make Equity a Reality? Ms. LaChapelle, thank you so much for joining us today. I will turn it over to you.
Thank you for that wonderful introduction, and I'm so glad to be here. And I really found the statistics, the stats that Dr. Camillo presented very useful. And my colleague, Antonia Wilcoxon, I always love hearing from her. I want to start today by talking about, we've bandied about the word equity a lot. And then we're talking about diversity and inclusion. First of all, let me define diversity. Diversity is through a lens, the definition is through the lens of understanding that race is a social construct designed and employed to justify slavery during the slave trade. Today, it's used in white supremacy as a means of categorizing individuals of different ethnicities, colors, and cultures as less than that of the white culture. Caucasian, ethnic groups, you name it, this is all a means of controlling the economy, who gets in, who does not get in the door, who gets opportunity, who does not get opportunity. This false equivalency has been used to afford those categorized with this extra unearned privilege. So diversity for me means persons of the human race from various and different ethnicities and cultures and belief systems, gender identifications, religious or non-religious affiliations, physical, emotional, and cognitive abilities, oh, and yes, color, have the same opportunities, the same chance to sit at the table and be part of the conversation, oh yes, and part of the solution. Equity does not connote equal by any means. Equity is allowing and providing opportunities for everyone to get what they need to lead their best life. With equity, some may get more of something than some others because more is needed for them to get to the starting line, while others may receive less because their needs are less. I think Dr. Camillo expressed this in his talk. When scarce resources and opportunities are given out equally, it only maintains the status quo of inequality and inequity. Inclusion is an operative word. It's one that's been bandied about lately. Diversity and inclusion. Every company has an officer who is supposedly over this. And it's a verb which welcomes all views, colors, ethnicities, and the whole thing again. But unfortunately, inclusion has been used as allowing a token individual of one of the marginalized groups entrance at the table, but not truly equal, not truly an equal voice in decision making. There's an unspoken understanding between those in power and the token to stay in your place and not rock the boat. I think Antonio expressed this. After all, you're lucky to be here. Don't screw it up, or we'll get someone else who understands what's expected. The book Cast by Isabel Wilkerson clearly explained that the problem in America and healthcare all revolve around an unbreakable caste system. This is a book everyone should read for themselves to better understand the quandary and quagmire we find ourselves in trying to navigate diversity, equity, and inclusion in America if real change is to happen. Another book is Dying of Whiteness that I feel should be read by all. As a nurse of 46 years who's worked in various hospitals and in public health settings, ICU, ER, I have seen the damage done by the petty biases, by the microaggressions that coworkers do to one another. I have worked where every day was painful and horrible, just walking under the door to come in and say, oh my God, I got to live through this again. Now, I say that to say this. There's a lot of mistrust in the African American and other communities of color against the healthcare system, but not just the healthcare system, against the structure in America that overshadows everything, and that structure is white supremacy. Many patients, many people have been ill-treated. They've developed certain mechanisms to deal with this maltreatment, which has not helped them much as far as survival and as far as staying healthy. They've internalized this anger, oftentimes expressing it against one another in violence or shutting down or in increased mental illness. The main problem is that we as public health members of the public health community and healthcare community, we owe a debt to society to be those change agents. We owe a debt to understand ourselves the effect of this systemic racism and how it impacts our community. I too am proud of Minnesota in many ways. I too understand that the disparities here are worse than the disparities in Mississippi. And we've got all the money and all the programming here that can make such a difference. But the problem are the people in the programming and programs who do not look at individuals as human beings, as fellow human beings. They do not look at them as people with needs. Instead, they look at many as someone trying to work the system. When I worked in the ER treating sickle cell anemia in Chicago, they treated it excellently. We had a large African-American population, and it was a regular disease to treat. Here, the few times that I've worked and seen somebody come in, there are more now, they were treated as though they were drug seeking. Now, sickle cell anemia needs to be aggressively treated with oxygen, pain medications, plenty of pain medication, and IV fluids. Those patients die early because of this disease process. The last thing they need is to be treated like, push them in the corner, they'll shut up soon. Oh, they're just looking for drugs. Ask yourself, if it were you or your family member, how compassionate would you expect the healthcare people to be? Now, my question that I was asked was, is Minnesota ready? I've got to ask you if you're ready. You're Minnesota, you're healthcare professionals. Are we ready to do what's necessary to turn this ship around, to help everyone feel like they're part of Minnesota and that they deserve everything that Minnesota has to offer, and that Minnesota becomes the leader as far as education, healthcare, health outcomes, and just quality of life for every Minnesotan, not just a chosen few. You have the ability, you have the power to get the knowledge, to understand how systemic racism works, and when those inherent biases in you start to rise to the top, and you're thinking, and believe me, patients can read your face, they can tell by your body language, you speak volumes without opening your mouth, even with a fake smile on your face, that you don't like them, you don't trust them, and you don't believe them. So I ask you, examine yourself. And then I want you, after you find these biases, they're there, we all have biases. You acknowledge them to self, and then you do the work to get rid of them and to try to, as hard as you can, and you can, it's a decision you make. Just like it's a decision every Black person makes to go back to a hostile work environment because they've got to provide a living for their family and they make the best of it. So it's a decision you have to make to do something about your biases and to work towards improving patient outcomes and being fair. You know what? Being biased, being racist, this whole system is destructive for the whole country. It's not healthy for anybody. And the book, Dying of Whiteness, it really breaks it down. But I want to thank you for listening to me today, and thank you. That's all.
Thank you so much, Shirlynn, for talking about your experiences, systemic racism, and the experiences that people of color experience in healthcare and just even leaving their house every day. And thank you for challenging us all to do the work today and moving forward. So with that, thank you to all three of our presenters today. At this time, we'll open it up for questions. We have about 14 minutes left here. So we'll get through as many questions as we have time for today. So please, if you have any questions, type them in the Q&A. And before I ask the first question, I just want to, again, thank all three of our panelists. Thank you so much for your willingness to share your expertise on diversity, equity, and inclusion, as well as talking about your experiences to really help us continue to learn and grow. So this will be for any of you. We have a question. What do you see, if anything, as a very promising public health or public health related policy, activity, or initiative for advancing equity in Minnesota?
I can start. So a couple things I would point out. One is that there was a resolution by the Minnesota House to declare racism as a public health crisis. That's set up a select committee on racial justice that did a lot of great work, put together a report with a lot of some concrete as well as aspirational recommendations for the legislature and the state government to follow up on as far as how do we really better embed some of these racial equity lens and assessments and practices, really looking at the impact of racism through the lens of health. And so moving forward, the work of that body and hopefully moving towards a statewide declaration of racism as a public health crisis, I think is some of the is promising. And then I'll use a real concrete example. Some of the work that Dr. Wilcoxon said we collaborate on is with the Integrated Care for High-Risk Pregnancies program, which is a collaboration between DHS and both the tribal and African American communities in Minnesota, really focusing on mothers and birthing persons, as well as fathers, as well as the community, and trying to get information out about early childhood, brain development, parenting, and all the different types of resources available, and have it be done in a way that is co-created by the community. That's also stewarded by the community. There's an advisory council, which Dr. Wilcoxon sits on, that really helps advise and steer how the funds for this program are spent, and has really shown success in engaging our community members around pregnancy, around parenting, and really helping decrease in those who are able to access it, decrease rates of preterm birth, low birth weight, completion of care. And so we got funding in the most recent legislative budget to expand that, because it was really launched as a proof of concept program. And now the intent is to really expand it so that all Black and Indigenous birthing persons in Minnesota will eventually be able to have access to that as they go through their pregnancy and postpartum care. And so really having policy that is, made again with community at the table at the beginning, throughout it, continuing to steward those resources. That's a kind of a model of development that I'm hoping that we can see in other areas of public health, of other areas of health policy going forward.
I'd like also to mention the recent opening of the Center for Antiracism Research for Health Equity at the School of Public Health. I have admired and followed with great pride the work of Dr. Rachel Hardiman, and I think it's such an incredible recognition of her hard work, her expertise, and the promise that it can bring some new learnings for us in this community to be at the University of Minnesota land-grant university. And thanks to Dr. Chomilo for your comment on iChirp, which is indeed a promising program.
I see, I totally agree with you, Dr. Wilcoxon. And please forgive me for calling you Antonia. We go back so far. We have a personal friendship, so I just forget.
Oh, you knew me before I was a doctor, so you're fine.
But I want to respect the title because I know the work. Well, in the chat, someone said basically what I felt, and I've been seeing, that Minnesota's not ready. They say if you see something, say something. But the healthcare organizations are not ready to deal with the issues. Often the person who says something becomes a target for microaggression, or worse, or outright, I don't know, where they just kind of single you out. And I have to agree, as a person who has called out things in institutions, it has not been comfortable following that. And that's too bad. If Minnesota is not ready, and I don't think they are, they better get ready. Because You know what? Countries, states, institutions, they all fall from within, not externally. They fall from within. And we cannot continue on the way we have been. This is a great state. The state does many great things. But my God, we should be able to get past this and be an example for the rest of the country.
And I want to build on that because I absolutely agree. I mean, you look at this time last year, almost every major healthcare organization put out a statement dedicated to addressing racial justice and racial equity in response to the murder of George Floyd and subsequent demonstrations. And so what have they done since? And I think there's some that could give you some ideas of some, concrete things, but how have they kind of structurally changed and reorganized their priorities to address, structural racism and inequity? There's an opportunity with paid family medical leave, for example, for them to really step up and put their weight behind it, or even change their own policies for their own employees, because we know that healthcare employs about 5% of the state, yet my paid family medical leave benefits are worse than many of the patients I take care of, their parents, and so I think really kind of continuing to push them on, what are you concretely doing, and how are you showing that it impacts your actual bottom line, that there's a commitment here, and not just hosting more conversations and putting together panels and groups of people in your organization to talk more about it, but like, what are you actually doing? Because as Dr. Wilcoxon, that Shirlynn have talked about, the evidence and work is there. It's been done. We need people that really step up and do things.
It's that challenge of moving to action. I think we have studied, we know the data, even if it's not defined in a way that helps us to see clearly. We know the nature of our disparities. We know what the inequities look like in Minnesota. And this is, we have been studying this for decades. It's nothing new. It's the fact that the promises made in 2020 have not, for the most part, been kept.
Make sure I'm not talking over any. Shirlynn, you're going to say something?
Just briefly, I agree with Dr. Wilcoxon. It's easy to make a promise, but following through, that's something else. The true leader, the best corporation in all of Minnesota will be the corporation that puts action to words and exemplifies what it means to truly be an anti-racist organization. They will find that their stocks, their profits will skyrocket. It's funny, when everybody feels that they are valued, everybody does put their best foot forward. They contribute 100% instead of 80, 50, or 20. When you make people feel undervalued, they don't provide their best. They give you what you have asked for, just as we know children do. If you want to see a brilliant child, and that's any child, you raise the bar. You tell them, oh my God, you're so smart. You start doing that and look at what you'll see. Even children who have been doing marginally in school start doing so much better because they want to get to that spot. They want what you said to be true. So I'm just hoping corporations will be that leader. Thanks.
Thank you, all of you, so much for truly challenging all of us and calling us to move to action from just talking and research. We have just a couple minutes left, so I'd invite each of you, if you have any final thoughts, to share with the group. Now would be the time.
I will just say that I hope everyone will be, I'm going to deputize everybody that's here to be co-sheriffs as far as anti-racist fighters, to help to dismantle the system of white supremacy that is helping no one, least of all those who are supposed to gain something from it. One thing about hatred, it destroys the hater and doesn't really destroy the person hating, as my mother told me when I was still angry at some friend, and then I noticed they're going down the street and they're talking to each other, and I'm odd man out. And I said, well, she was mad at so-and-so, and so am I. And my mother said, you know what, they forgot that mess, and you need to forget it too. You need to move on and move up. And so I'm asking everybody to move up and move on and help us get to the place that we say we want to be as a society and as people involved in the health and well-being of our community and our state. That's all for me.
And I just, challenge folks, when you hear equity, when you hear DEI, really dig into what are folks talking about, because they become these terms that are like ubiquitous, and folks think that, by just saying them, that then they're virtuous and that's enough. But we really need to be asking, what is your definition? What does it mean? And if they're not talking about structural racism, they are going to be missing the point. And so really that has to be a part of it. There's other parts of inequity for sure, but structural racism cuts across all of them. And so really challenge folks to don't just stop saying, oh, this is a DEI initiative, this is an equity initiative. No, what are you really talking about? What do you hope to accomplish? How is community involved? And go from there.
And I'd encourage everyone, embrace that discomfort. If it feels that it's a bad fit, you're in the right place. You just need to grow accustomed to that, because you're changing, you're moving, you're transforming. And our great state deserves better than this. I think that the way that we have lived and the way that we have accepted the circumstances cannot continue on if this is to continue to be a great state. I think liberal and tolerant and all the terms that we use to describe Minnesota have no longer become something we trust or believe in. It's out there, folks. If 2020 didn't teach us anything, just look at the voices that were on the streets, and they were many and they were diverse. Some bravery, some courage that you didn't think you had, find it within yourself. It's worth it. And our state was so much better for it. Thank you.
Well, thank you all so much. On behalf of the School of Public Health and the SPH Alumni Society, thank you so much for all of you for sharing your expertise, experiences, and recommendations and challenges for us all moving forward. And thank you to our attendees for joining us today. We will send out a follow-up email and include some of the resources that were shared today, as well as the recording. I hope everyone has a great rest of your day. Thank you.